we start the recording? Great. So good morning, everybody, and good afternoon to those joining us from Europe. It's a real pleasure to have a good friend, Mehta. Samir is one of the people I truly respect when it comes to Stemi and interventional cardiology in general, but I've learned so much from working with you, Samir, from listening to your lectures, from working on your multiple textbooks, and I really hope, we can continue that collaboration, particularly as we work here at Monty and we continue to try and improve our STEMI care here. So thank you for taking the time to talk to us and to talk to our fellows today.
Naseem, thank you for the introduction. It has been an absolute privilege knowing you, and I know you're doing a fantastic job here in New York. And I think this particular initiative is absolutely world-class. So with this, I have slightly modified the talk as I communicated with you. Look, it's going to be a lot of fellows. Let's see if we can give them some guiding tips and tricks. And I have also additionally invited some of my own fellows to be joining. So this is my objective, to take lessons which are numerous. This has been a unique practice. Just completed 21 years of a STEMI only, which even I did not believe would be possible. This is the work of the Lumen Foundation, going beyond my own sincere database in Miami, which last night I did my 2,913th STEMI. No fellows, nothing at all, from cannulating getting access to even removing the sheets. 33 countries. These are the programs of the Lumen Foundation, all related to creating STEMI network, mainly in the poorest part of the world. And of course, I'll share some details with you. So this is one of the first lessons I can teach your fellows, Aseem, and to our global audience. And this is something I published in my first book in 2002. And at that time, I figured out that to help manage and to prepare oneself for doing a STEMI, you need to immediately understand that there are two parts. There is a process, how a patient comes to you, which is pretty unusual and unique and different in any part of the world, in fact, even in any city. The procedure, fortunately, is straightforward, nothing to it. So it is extremely clear. And as I look at my own career for 21 years, I would say that it probably took me less than 6 months to absolutely master STEMI. Some of the lessons are there straightforward. If you are doing a rotablation of a heavily calcified tortuous proximal LAD and putting in impella catheter, doing a STEMI is truly a piece of cake. However, what makes STEMI unique and difficult is the challenges to deal with the process day after day after day, and which is why people get exhausted, the staff gets exhausted. Again, there are new issues regarding patients who really are rushed to the cath lab, the false alarm. We'll talk about it. But very important for all of you to understand, particularly this single slide helped me create STEMI networks around the world, because most of the time, correctly, I was focusing on the process. Now, this is another great lesson for you. STEMI is a blind date. Okay, so you are Aseem Lateef and highly accomplished over the last 25 years with the incredible experience in Milan. And, this is how I used to be. It takes me 9.2 minutes to do a STEMI. But what if your blind date is this? Now, this is a 450 pounds gentleman with a massive anterior wall. And, normally I'll show you in the next slide, it takes me, a minute or less to get access. Try getting access here. And what if your blind date has 17 stents? And what if, forget about all these, what if you are fortunate or unfortunate? Most of the times, this is what a STEMI is the next slide. STEMI is this. This is what we are dealing with. So this is one of the best lessons I have always taught people. And here is the lesson. The only event you control in a STEMI process is how quick you are to abandon what you're doing, jump into the car and start the process. That to me is the key, particularly for those of you who are going to be getting into practice after your cardiology and interventional cardiology, starting your career. This is the discipline you need to. Now, this is a little bit of a personal, some of you may find it even a little difficult to even call it. There is no vanity here in this process. If you do it as long as I have done it, you become very humble. But this is what it means, that if you're going to be doing a lot of STEMI, again, I don't think anybody would be stupid and foolish to do what I have been doing. You're going to require a lot of lifestyle change. At least on the night you're taking a STEMI call, there are going to be logistical challenges, and let's show you some of this. So this is how my cars are parked in the house for the last 21 years. This is how this is what is there in the car. This is how I still sleep, ready to go. It's all military planning, haven't changed that. The car is parked right next to the cath lab. This is you're constantly communicating with them. And here, people ask me, can you do 2 STEMIs together? I've done it 76 times. 3 STEMIs together, 11 times. 4 STEMIs together, twice. 2 patients with simultaneous cardiac arrest on CPR, another 3 times. And I'll show you some of these, all done. This was a little harder. This is, I think, 2011. I tore a meniscus, and these were 20 days done on crutches. I used to leave the crutches outside the cath lab. This is one of the loveliest stories. I'll come to that in a moment, but let's finish some other challenges. Here we go. 54 times stopped, 37 times to the court, and survived 5 of these also. So I'll go back to this, and this particular, here we go. This is one of the loveliest lessons you will have. This is 2013, New Year's Eve. I've been invited to the home of a very wealthy Miami attorney. They are going to name Dr. Samir Mehta Day for my STEMI work. The mayor is there, and at 9:30, as they are calling me, I didn't even realize I was on STEMI call, and there comes a 39-year-old with the cardiac arrest. So I told our son, who's visiting us from Oxford here, and my wife, who has never seen a STEMI, is just foolishly believes her husband is the most talented STEMI interventionalist on the planet. And so I told them, look, you go ahead, I'll join you. And she said, no, you come back and then we'll go. I said, you know what, come on, it takes me 9 minutes to do a STEMI, come with me. So this is the humility which STEMI brings you. This picture is 3 hours, 25 minutes later. My son is there. My wife, who has only seen me bragging about my skills, watches, and 3 hours, 35 minutes later, at around 1 in the night, the patient passed away. So I always use this slide to keep myself grounded, and that irrespective of how experienced you are, STEMI is something which requires particular speed, skills, and most of all, judgment. And those are some of the things I'll be trying to give you examples of. So here is something else which I tell people, all of us have created a mechanism, how we do a TAVR, how we do a bifurcating lesion, whether you're going to be using a mini crush technique or a SKS or the DKS. And same way, I've had this approach. This is how I do a STEMI. Let's start the car. Here you go. So here is giving local xylocaine anesthesia, whether you're taking a radial or a femoral access, no challenges at all there. I always do a complete angiography of both the left and the right. Here is the guiding catheter. I like to use hydrophilic guide wire. I do a lot more thrombectomy than others. Here is the stent. I always use tons of intracoronary vasodilators, often do a hand injection to assess the LV, and there you go. So let's, I always think this is a unique slide. So once again, here is the same mechanism, same thing, night after night, build the discipline, more and more radial access, always try to have a great access. You don't have good access, everything goes wrong, always complete angiography. I like hydrophilic wire, although that is no big deal. I use a lot of thrombectomy, we'll show you cases, always a drug-eluting stent, intracoronary vasodilators, assessing the LV function, often with just a hand injection. So let's teach you a few procedural lessons, and here they are. So here you are looking at the EKG, and I mean, this is no big deal, no? This is straightforward. I mean, it's staring at you. Now, the key here is that, again, a lot of indications. This slide I made is in 2003. In 20 years, much has changed. But if this is the purpose, which the purpose of a STEMI is to save a life, not to chase these lesions. So if this is a patient and you know clearly the focus is your RCA, and here is a 100% probably thrombin-laden, very acute infarct, that's what you should be doing. Here is no reason to be chasing all this. Here is another patient. Once again, here is your culprit. And why would you be chasing all sorts of lesions? Now, again, guidelines have changed. We'll go into that. But I think, I mean, almost always, I do not remember ever walking into a STEMI and not having identified the culprit lesion. These days, it's so easy. You know, they've already sent you the EKG from the ambulance. I'm on the phone and I've told them, you know, pull out a JL4 guide, a choice PT wire, keep a 2.5 millimeter balloon, an aspiration catheter, and that's how every STEMI is planned. So this is something probably, I think, the single best lesson beyond that blind date. Know when to stop. Here is a patient who comes and 100% distal RCA and excellent result. So why are you chasing all this now? You're done. You're done. You saved the patient's life. This can easily be monitored and followed up later. So try not to go down. I mean, I often see whenever people are doing STEMI, you know, they focus on small little side branches and they are putting in IVUS catheters. I have not done a single imaging in 2,913 cases over 21 years. It is rare for patients to be going for open heart surgery. Again, I think it may be needed in cases, but keep the matter simple. The job is to save a patient's life. That is where I think is the real indication of a primary PCI. Here is another patient, another RCA, excellent result. And now you're chasing all these and getting into trouble. So keep the focus, identify the culprit, know when to stop, save a patient's life, you're done. This is something else. Again, there's probably such a simple slide, but it has wisdom of 21 years and thousands of cases. So before I take the patient off the table, these are the 4 parameters I'm looking at. Is there relief of chest pain? Mostly you will have it, not always. There could be some residual lesion, concomitant ischemia from something else, a few other ST segment resolution, you start seeing it. TIMI grade 3 flow, almost always you get it, and people think that, you know, once they have got TIMI 3 flow, it's a successful STEMI. Not at all. It is number 4, which is the myocardial perfusion grade 3. Stop your focus only on the coronary artery, and we'll talk to you more about achieving something like, and this is what I do. I probably am the single person, I think, where my personal experience is different than most others. And again, it often sometimes goes beyond the standard academics, but look, 21 years of doing it probably is worth a lot. A single individual doing almost 3,000 cases. So this is a philosophy which I have always had, which I hope can be beneficial for you. Just about every component of what you're doing in a STEMI intervention causes distal embolization. So let's take a look. Here is a patient presenting with STEMI. This is a thrombotic lesion. Here we put in the guide wire. And even this mild, relatively non-intrusive, here it knocks off a couple of distal vessels, the small capillaries. And if you are putting in a balloon, this gets much worse. In fact, I try not to even use a balloon. Often it's going to be either direct stenting or probably some form of a thrombectomy. Let's try to put in a stent, and this is what happens. So at the end of the case, if you realize you've got TIMI grade 3 flow, but it is the myocardial perfusion which makes the biggest difference. So what I have been using is using lots of nitroprusside. When I started my career 20 years ago, I used to use 50 mics and I used to freak out. You know, the blood pressure always comes down. No big deal. I use a lot of intracoronary neosynephrine simultaneously. So at the moment, this is again with the low dose, just a cartoon. And this is what I have been using, higher and higher doses of intracoronary vasodilators. You can use verapamil, you can use diltiazem, nicardipine, so many agents. I like to use nitroprusside just because of familiarity. And I think all you do is, so I'm giving higher and higher doses of intracoronary nitroprusside till you have achieved not this, but this, always with the firm belief that it is a distal myocardial flow or the blush which makes a difference. Often I'm using 600, 800 mics and almost simultaneously intravenous 200 to 300 mics boluses of neosynephrine. And this is what you're trying to achieve, always myocardial perfusion grade, which I think makes a enormous difference. Here are a couple of cases before and after. For the right coronary artery, always you're able to better appreciate it in the RAO. For the left coronary artery, it doesn't even matter that much, but it is this kind of a perfusion which you need to be achieving at the end of the case. Just getting TIMI grade 3 flow is only a part of the story. What about the thrombus? So once again, as I mentioned here, I've been a far bigger proponent of thrombectomy, particularly as our door to balloon times have come down, as patients are presenting early. In the very early part of the presentation, you're basically dealing with a fresh friable thrombus. And as time goes by, and this is around the time, if you look at the EKG carefully, you've got a patient with the pure ST segment elevation. You're probably dealing in this situation. You've got all fresh friable thrombus. As you start having some Q waves, ST still persisting, you're dealing with the more of a gray thrombus, a white thrombus. This is platelets and far totally different methodology to treat. So whenever you're doing it, all again, there is always the role of dual antiplatelet therapy. I like to use still a lot of bivalirudin. Heparin works absolutely fine. Almost minimal to zero use of 2B3A. This slide is 2004. The message which is true is about the thrombus. And again, a lot more thrombectomy, and we'll show you how to do it. So, and a lot more use of both aspiration and mechanical. So this is what I call it a Mehta methodology of performing thrombectomy. Almost always, as I have taken the first picture, I have assessed the patient's what I call as a thrombus score, whether there is no thrombus, which rarely happens, to some amount of thrombus, where I like to use a aspiration thrombectomy, and something much larger in vessels which are large, I still use a lot of mechanical thrombectomy. This has all been published widely. You'll be able to take a look, and hopefully this is a nice methodology to take care of thrombus, but it is the intracoronary vasodilators which I think are the real key. So let's show you a few mistakes, and hopefully you'll learn some lessons. Here is the first mistake. These days, this doesn't happen more. In 2003 and 4 and 5, when we were trying to chase these door-to-balloon times of 90 minutes, I mean, you missed a door-to-balloon on 90 minutes. Even the guy at the gas station knew that you got it in 105 minutes. Okay, this was our focus, and almost being naive that as if this is the only matter which makes a difference is absolutely ridiculous. Towards the end of the talk, I'll talk more about focusing on symptom to balloon time from the first medical contact. But this is what we were doing, and this is the mistake which happens. You'll go into a practice, you'll start at a new place, you'll start taking semi-call, and now you're looking at, oh my God, there were all sorts of delays. The patient is coming to you late, access was difficult. You need to get it at 90 minutes because this would be a blunder you would be making. And what is the commonest mistake? Here is a lesson. Here is a patient who comes here, has a critical thrombotic lesion in the distal part. Here is the quickly putting in a stent there, and here you go. That's a decent result. And you raise your hand, STEMI done, door to balloon time 88 minutes. And this is 3 hours later. Okay, so again, this required a much more compulsive thrombectomy, and this is the final result. Of course, the patient did all right. Here is another patient, inadequate thrombus removal. Here is another totally occluded RCA. Here is a quick, silly way of doing it, putting in a balloon, putting in a stent. You believe you have a good result. Again, an hour later, and in this case, much better thrombectomy. And if you take a look here, this is what I call myocardial perfusion, and that is what you need to achieve. So inadequate thrombus removal. Let's show you another mistake. Similar patient, here it is. These are all mistakes made. Patient comes, you do a quick stenting. This is a decent result, in fact, an excellent result. And again, a couple of hours later, and in this particular case, this is a very large right coronary artery dominant. I did 3 or 4 passes with the angiojet. And again, this is the final result. So inadequate. Now, another horrible mistake which we made is we almost always, I can't tell you, this is by instinct, I oversize what I think is the vessel size. Okay, because we underappreciate the vessel. There is a diffuse spasm, there is thrombus, there is a you almost always get it wrong. So by instinct, I use a quarter size stent bigger than what I would normally do for a patient in an elective case. So here is a patient with a totally occluded RCA. This is the, can you imagine here? You look at it, and I don't know what I was thinking. This is a 2.5 balloon, and I think it was stented with a 2.75 or something. And here is the result a few hours later, and I looked at it carefully. This is doing angiojet here, again, a very large right coronary artery. This is a 2.5. Here you go. This is a 4.0. So we grossly undersize. Keep that in mind whenever you are doing a STEMI intervention. So these are, so far as the procedure is concerned, no big deal. STEMI is not difficult. Be mindful of keeping a standardized technique. Watch for vessels which we think we undersize. I am very compulsive in thrombus management and use of intracoronary vasodilators. I truly believe I have not, unfortunately, be able to publish it as extensively as I should have. Will be doing so very soon, but a far greater use of intracoronary vasodilators and a belief. And I particularly use the intracoronary nitroprusside, large doses. You have hypotension, use neosynephrine, it is no big deal at all. Never had anybody going into VT with that or heart blocks or anything. Now let's change the area, and let's, we may be having a global audience today. Aseem, you always do a fantastic job in disseminating our work. So let's talk a little bit more about STEMI around the world and a few other process-related aspects. This is not Photoshop, okay? This is Sao Paulo, Brazil. The disparities come so clear in a slide such as this, and you're able to watch what is happening. So on the left side is 85–90% of the world. On the right side is the privileged class. I often, I have written about it, that what would be the outcome of if I was having a STEMI. So this would be zip code 10026, New Delhi, India, where I grew. You have a heart attack there, forget it. The first thing you have to do is to be educated that somebody drives you to a hospital, because there is not going to be any ambulance. And once you're ending up in a hospital, it's a pretty good chance that the best they would have there, even in 2022, is streptokinase, okay? And now, what if you were having a heart attack in 10033 in Miami? In 4 minutes, a sophisticated ACLS ambulance will be there. They'll be doing an EKG, which is immediately transmitted to the interventional cardiologist, let's say Dr. Lateef, who's there. And as the patient is coming to the hospital, Dr. Lateef and the team are driving to the hospital. By the time the patient has even hit the ER, we've become so sophisticated that in some of the cath lab, the first person who reaches the cath lab presses a button which lights up a green light in the ER, and the patient has an ED bypass. And fortunately, my artery is opened in 42 minutes. And I go home on the second day, and that's the end of the story. So this is a reality. And as I did more and more and more STEMI, I also created, I've done 20 years of a STEMI only meeting. 10 years were in the United States, 10 years I took it in Asia. The more I understood it, global STEMI is all about the process. The procedure is straightforward. It is the same whether it is in Bangladesh or in New York City. Exactly the same. You may be using a little different thrombectomy device or having a slightly different stents, but just about the same. And almost everybody, if you're able to improve the process, you're able to do a good procedure. You have to realize that the slide I showed you with the thrombus, you can never get a patient with a fresh friable thrombus. You never get a patient with a straightforward massive 8 millimeter ST segment, which I get in Miami. You're almost always seeing ST segment with deep Q waves, thrombus, which is going to be dense thrombotic. Now you're struggling in a case, the patient in various parts of the world, they have a pharmacoinvasive management. It is a struggle and struggle. So my entire 15 years of my work globally has been trying to understand these disparities. And this is one of the solutions which we found. And this is a lovely paper which we wrote, A Tale of Two Cities, STEMI Interventions in the Developed and Developing World. And this particular experience, this is again in a single slide, 10 years of my life, creating 275 STEMI networks in South America, in Colombia, Brazil, Chile, Argentina, and Mexico. This paper has been recently published. I'll show you the exact publication area. And this work started in 2008, creating first in Colombia and making just about every mistake there is possible. Challenges like you cannot imagine, challenges with technology, challenges with personnel, with equipment, of course, the biggest with the ambulance system. And then one after the other, years and years and years of work, almost 6,000 people involved in the initiative, 275 centers. And this program now is an absolute beacon, a template for STEMI interventions anywhere in the world, but particularly in the sub-Saharan region of Africa, in the Middle East, Far East, Southeast Asia. And straightforward template. Nobody has to even bother about changing it. Just copy and paste. This is years and years of work of hundreds of people. Absolutely similar methodology which has been used, creating a hub and spoke pattern. 275 centers, whether they are in the jungles of Colombia or in the vast, very poor population of Brazil. This is a possibility of telemedicine, and I am absolutely privileged. It's been a very, very remarkable and difficult journey, but this has completely changed and revamped how we can approach STEMI interventions, which is all population based. So this is the work which was published last year, STEMI Telemedicine for 100 million lives. When I mentioned about the Lumen Foundation and doing its international work, almost all of it was creating networks in the poorest countries, and several of them have started using telemedicine. Telemedicine in a very organized manner, in which you are immediately, there are two parts to it. You make as close to 100% diagnosis by an expert who's looking at the EKG, and then most importantly, you're able to triage the patient into a thrombolysis, hopefully with a second or a third generation agent, into a pharmacoinvasive methodology or a pure primary PCI. When we started doing this work in Barranquilla, was the first city, 78% of the patients used to self-transport. This is the benefit when you create a program, nationwide program like this, that almost 86% of the patients are now coming via ambulance. Almost always, I can tell you the gains. I don't think I have ever taught an interventional cardiologist anything so spectacular about doing the procedure, but I have almost always identified the issues they have with the process, and that is essentially what you're able to do, how you're able to eliminate disparities. So here was the model of telemedicine in Brazil and Colombia. And we used to have a telemedicine device of $300. It used to take $5 to, actually, $300 device, $3 to diagnose, and less than 3 minutes to start the process. So I almost copied this and took it to India's biggest state in Rajasthan, the most largest in size, the population of 65 million, which is the same as the population of France, and a size which is the size of almost Texas, and created this model. It's known as the Rahat program, the Rajasthan Heart Attack program, and we are even able to bring down the cost from $3 to $1. So this is the beauty of STEMI interventions. In this particular case, we have incorporated all sorts of technology, and we also do, 2 electrocardiograms, and almost 60 to 70 to 80% patients are able to bypass the ED. I always tell people what is the next frontier in STEMI. I truly, we did a little research here at 2 of the hospitals and in Miami. And shockingly, we realized that the 2 commonest events which were happening in the emergency room, again, please don't take it to an absolute literal extent, but the commonest events which are happening for a STEMI patient in an emergency room are registration and insurance verification. And that is how we are using 27 minutes, create sophisticated methodology. If your process is good, if you respond quickly, if your pre-hospital activation is good, you can virtually bypass the emergency room in the overwhelming majority of the cases. Even if you don't bypass, don't take the patient off the gurney, because just removing it from the gurney onto the bed and back, and that takes a lot of time. Just some practical ways to eliminate door to balloon times. So STEMI frontiers. I think for too long we have been obsessed about door to balloon time that we have forgotten that it still takes all over the world on an average 2 hours and 43 minutes. This was a lovely study from Leeds in the UK. 2 hours and 43 minutes on an average for a patient. And so Dr. Lateef and his team are driving. He's driving at 100 miles an hour, like me, getting stopped, getting accidents. The team is struggling at 3 in the night. Patient was having chest pains in 6 hours. Too many resources not focusing on what needs to be on the first medical contact, the symptom to balloon time. Now, this is also hard because it is so hard to educate a patient. And is there something which could be done different? So this has been my work using artificial intelligence over the last 7 or 8 years. And when we were doing the telemedicine program, the telemedicine company out of Sao Paulo, Brazil, they have access to 27 million electrocardiograms. And we got some sophisticated artificial intelligence, machine learning algorithms, started looking at all sorts of possibilities, how this could change. What if the process is triggered by a patient? What if a patient is able to diagnose his own STEMI? And this is what I have created. This is our work of the work of the Lumen Foundation in artificial intelligence. We publish a very beautiful, Dr. Lateef, monthly newsletters. Let your fellows and all the physicians worldwide let us know. Go to, this is fameglobal.org. Fame starts for Forum for Artificial Intelligence in Medicine, and that is what we did. So I've created, I already have US patents. We are looking into FDA guided trial. Self-administered single lead artificial intelligence detection. I can put this device, the algorithm, on a watch, on a pad which can be placed, or on a ring. You put a ring around the V2 and a patient is immediately able to diagnose. Not only that, this device is so sophisticated that as soon as it detects STEMI, it also summons the ambulance. So this is the purpose of showing this, is to tell you, help you understand, to focus on a first medical contact, the first symptom, the symptom to balloon time. Last 3 slides, STEMI interventions. I sit here with this incredible program. Hopefully it is beneficial to you. I look back at my life and I said, what has been achieved? Door to balloon time used to be 120 minutes, 180 minutes. It became 120 and 90. Now, 21 years of experience, 2,913 cases. It's down to 51 minutes in 5 hospitals, community hospitals. It is unbelievable what can be done. A Latin telemedicine program which creates an umbrella of protection for 100 million patients. I've been speaking before Corindus got sold to Philips. We were thinking about doing a robotic STEMI where I could be in my office here in Miami and do a STEMI in Luanda. All of this. But here, let me show you some things which I have been able to do it here. So this is, as I mentioned to you, STEMI is all about logistics. Here is a 2 simultaneous STEMI. Piece of cake, you have it, start one, quickly inform somebody, have the other patient outside the room, and no big deal at all. And this was at 3 in the night. Something else, which is, I take a lot of personal pride. This is Hurricane Irma hitting us, and it's getting closer and closer. And here you go is the chart, and this is what's happening all over. And so I'll show you. This is during I think it was a 24-hour or a 36-hour period. And these are STEMI interventions going back and forth. And here we go. I said, look, the safest place so that one could help. And for whatever reason, I've been through several hurricanes in Miami. In this particular case, there were 15 or 16 consecutive STEMI, and all done, all excellent result. And you come home and you realize, oops, the problem with the hurricane isn't over. So I call it my hurricane STEMI experience. These are the 16 cases done during a hurricane. Just unbelievable what this procedure can do. This is the last story, hopefully inspirational in what, not me, what we have done as a society. I have always believed that the contributions of the interventional cardiologists, the contributions of the nurses and the techs who run night after night after night, always it is in my first book, it is written, the nurses and the techs are the unsung heroes of a STEMI intervention. This is a Carnival cruise line, 22 miles off the coast of Miami. Their senior engineer has a massive heart attack. Now, there is no ability to land a helicopter there. So the captain is so smart, he quickly navigates the massive 3,000 passenger ship into the international waters. They told me it took them about 26 or 28 minutes, at which point the Miami Coast Guard evacuated, moved the patient. It took them 7 minutes to get the patient. We have in one of the hospitals, Mercy Hospital, there is a lovely port which has been created exactly for this. The STEMI intervention was an 11-minute procedure. I call it the magic at Carnival, the possibilities of STEMI intervention. More recently, Dr. Cindy Grimes and I have written this editorial that although much has been done, far more remains to be done. Asim, I'm going to stop here and delighted to take any questions, and I hope this has been useful.
Samir, yeah, I'm almost speechless. It's really been inspirational. For many of us, including myself, the reason we became interventional cardiologists was because of STEMI, was because that's what attracted us to doing interventional cardiology, was primary PCI and the ability to very quickly open up somebody's artery and save their life. So, I found your talk really inspirational. I want to thank you as well from all of us and, all interventional cardiologists for all the work you do to promote STEMI care, for Lumen, and how you promoted, STEMI care around the world. I think it truly is inspirational. I think for the fellows also, I want to highlight, if someone chooses an area and really dedicates their career to that area, it just shows how much can be achieved. So congratulations again. And we really admire you and thank you for spending this hour with us. I'm going to pass you on to our fellows now, because in the end, it's all about training the next generation and making sure they continue to do all the great work that you started. So I'm going to pass you, I'm just going to go according to my screen here. So Pier Pasquale, why don't you go first? You're first on my screen.
Hello, Dr. Mehta. Thank you so much for this great lecture. So, I think you're the right person to ask. You were saying how you use quite a bit of thrombus aspiration. We know the results from, like total trial, which assess like routine thrombus aspiration. But I think, and I do believe, like you said, that whenever you know how to use it and when to use it, I think it's a good device that you can add in STEMI procedures. So my question will be, how often does it happen that you actually do, like if you were to say a percentage of cases of thrombus aspiration, and how often does it happen that you only do thrombus aspiration with no stenting? And one last question is for us fellows, if there is any advice in manipulation of the thrombus aspiration catheter whenever we use it. Thank you.
All lovely questions, Pascal. Sometimes in medicine, just wondering,
Maybe everybody else just mute yourselves.
Mute it, yeah, that would help. Okay.
Wait.
Yeah, that helped. Asim, thank you so much. So, Pascal, often what happens, I say it with a very, very careful, when I make the statement. My personal experience has been more than any of these, the biggest of the trials. So I think, there is, and I called this, my work, Sincere Database. Single individual community experience registry, a single interventional cardiologist doing STEMI at 5 institutions, night after night, of course, one at a time. And you look at it, and I called it sincere, no conflict. I mean, at this stage in my life, I don't need somebody to coming and knocking a door, oh, use my catheter and all. 71% of the patients over a 21-year-old career, 2,913 cases, each all documented, required thrombectomy. However, over the last decade, that number has come down to about 50, 55. Now, majority of the time, the particular aspiration catheters have become so easy to use. It's straightforward. Yet you look at it, these are truly, we look back 10 years later and said, look, it's a shocking. I used to use this aspiration catheter. I mean, silly thing, with the syringe at the end. And I think technology has truly slackened in that. So tips and trick, you have to realize if you're using the export catheter, the commonest mistake is done. You have to be certain that you are negative as you are approaching the lesion. And again, look, the export or the aspiration catheters are easy to use. It is the angiojet which I think is harder. And I think it is an absolute, I've got a collection of about 60 cases, 63 or something, which the aspiration did not work. And of course, the thrombectomy with angiojet. Again, you have to be careful, use it in bigger vessels. It can be used for vessels greater than 2.5. I think that is truly pushing it. There are vessels, 3, 3.5, 4, and particularly the right coronary artery. The trick there is to be sure you've gone through the entire length of it. A great device. So just about minimal thrombus, I think you can direct stent. There's some thrombus, patient presenting early, large ST segments. These are the ones which I kind of showed you in that slide, have the red, fresh, friable thrombus. Aspiration works very well. But if there is a patient coming 6 hours later, chest pain is almost all gone, deep Q waves, now you're looking at dense thrombotic, these are the kind of patients you probably may benefit with the mechanical.
Thank you so much.
Samir, there's a question from one of our colleagues, I think from Pakistan, who asks, when in your STEM interventions do you prefer deferring stenting? So, I don't know, maybe large thrombus burden or something.
Right. So Pascal had actually asked that question. Sorry, I forgot to answer. It doesn't happen often. I go around the world and people show all these great cases where they use the thrombectomy only, more of a erosive pathology. Patient comes, or a young woman with the presentation or a inflammatory pure mechanism. I look at 21 years, probably done handful of cases where there was only the vessel opened only with the thrombectomy. Doesn't happen. The more common situation is the reality which happens around the world is you've got a patient, the process was so deficient because, look, these are the harsh realities. I mean, STEMI intervention, that's where the slide I showed between the two worlds. Can you imagine STEMI, which is happening in parts of Bangladesh and in sub-Saharan Africa versus New York City? It's a world apart. So the real decision to me is often you have patients who are coming late. Should you do anything? That to me is the key. And, deep Q waves, if you're able to do a quick echo, there is a akinetic. You have to realize this is, I used to have a lovely slide where I used to show, I mean, the way cost of healthcare is, you have a patient who's had a heart attack, and now you're doing a needless procedure after a completed infarct, and then the guy is selling his house. So fiscal realities are very important.
Yeah, it goes very well with this comment from one of the colleagues who is from Bombay and talks about, that there's a lot of, I like this word she uses. She calls it perfusion injustice, in the sense that there's often a lot of delays because patients are waiting to get financial approval, and they're paying cash as well to have their STEMI and their artery opened. But she does raise one question, which you raised. I actually took a photograph of your slide because I think one of the most important things, one of the slides I liked the most of yours was the one where you talk about, when do you consider the artery is actually open? Your job is done in the cath lab, and too many of our young attendings and young fellows, they think TIMI 3 flow is enough. They forget about the whole, microvasculature and improving microvascular perfusion. So I really love that slide. But this colleague asks, and I think this is a question we face here in the Bronx, we see a lot of late STEMIs, patients coming late, even 1 or 2 days later, they've got already some Q waves, and then they've got LV dysfunction. And then we continue having this discussion with our heart failure colleagues about, do we open the artery? Don't we open the artery? Should we do MRI to check for viability? Are we risking giving the patient reperfusion injury? So maybe just a quick comment on late presenting STEMIs.
Exactly what I had mentioned. This is what I see around the world is the late STEMI is the challenge. I think whatever availability you have to demonstrate a viable myocardium, I think should be exercised before we go ahead. And there is no magical cutoff, whether in Miami that could be 18 hours, in New York City, 12 hours, 24 hours. I think whatever evidence you can get that there is viability, proceed only then. Otherwise, no point chasing it.
Great, thank you. Nikos?
Thank you very much. That was a great talk. I learned a lot. A question I had is, where in your algorithm of STEMI, in a patient that presents with cardiogenic shock and STEMI, where would you put the mechanical support, or if you need to support the patient, would you open the vessel and then support? Would you support up front? And if you had to create a universal algorithm, a global algorithm, how would you make it, taking into account that in some countries we don't have the capability of putting like large bore devices, impellers and whatnot to support those patients, and if any, they have a balloon pump to support them?
Absolutely, lovely question. So this is totally different whether the patient is in Ghana or is in New York City. If you're using an impeller, there is enough evidence today that you first support the LV and then perform the PCI. Again, logistics often get different. Majority of the patients are being done through the wrist access, and you have to quickly put in an impeller. So clearly, if there is a particularly anterior wall, large myocardial infarctions, always better to start perfusion therapy with the left ventricular assist device if you are fortunate enough to be having impeller. Around the world, it's a very, very tricky thing, and all the algorithms are, the economic realities far supersede any of the scientific principles. If you do have patients with cardiogenic shock, I can tell you impeller is not available in the overwhelming majority of the world. Again, your intra-aortic balloon pump is the best hope. How much does it do? It's always remained questionable. So I have a great slide. I used to call it, 4 reasons whenever I have a patient with a cardiogenic shock or something, that the question is going to be, should you put in a left ventricular assist device first, or do a primary PCI. If the lesion looks straightforward in a proximal portion of either the left anterior descending or the right coronary artery, I mean, the left circumflex, I don't even consider it as a life-threatening STEMI. Rarely you would have somebody from a OMB die or something. It's all proximal RCAs, LAD. Large vessel, large area of myocardium under jeopardy. If there is a straightforward lesion, which you can probably do in 2 or 3 minutes, I still sometimes will immediately do that. And you are absolutely shocked. There are so many patients coming with the profound shock, particularly involving a proximal RCA. You've opened it and the patient is magically, I mean, the cardiogenic shock is all over. So there is that. So my feeling is for sometimes, and I think that's where the data seems to be suggesting that it is the anterior wall where a patient with cardiogenic shock, that the true benefit or the biggest benefit of a impella is there for these. A lot of otherwise, but if the lesion is looking, you've taken a picture, lesion is looking technically challenging, no, always put in a balloon pump or a impella before you do a stent.
Thank you.
Thanks, Samir. Jesse?
Thank you, Dr. Mehta, for an excellent talk. One of the things I really appreciated about it was that there were a lot of personal aspects to it in terms of how you personally manage things or your system to responding to STEMIs. And as someone who's going to be going into this, it's definitely inspiring to see your enthusiasm after 2 decades of it. I guess I would then ask you a personal question. What have you found are your best tools for resiliency or managing the lifestyle? I mean, I've been doing this for now 2 years, coming in the middle of the night and trying to figure out how to take care of patients the next day. What are some ways that you've been managing to stay healthy and fit for 2 decades of it?
Right. So lovely question, Jesse. As beautiful a question as anybody has asked me all over the world. I have often over the last many years thought about it. I mean, it's just physically, it is so difficult. And then I said, you know what, I have all my life, I have believed in it so much that I want to. There is a lovely slide. I have a quotation from Lord Buddha. You cannot be the path unless you become the path. So somebody has to do it. And that's why I said, you know what, and there have been numerous times I said, look, it's too hard. But the beauty of it is as much as, and I often teach my students this, that there is a 2 part of it. One is you're rushing, you're exhausted, you're tired, you're having accidents, you're speeding. And then you've done this magical procedure in 9 minutes. I mean, that's the indication for PCI. I mean, the rest is all hocus pocus, you put in you start doing IFR, half the lesions disappear, you start talking, you follow. I mean, this is straightforward, life-saving. And therein, I just mentioned something, use this procedure as life-saving. Now, the first slide which I showed you, the blind date, that has been the single best practice which has helped me. I immediately abandoned. There is no question of it. Whatever I'm doing, I am in the car. In 21 years of doing it, the greatest contribution I have made to STEMI interventions or to Miami is it has never taken me more than 2 minutes to get into the car. Okay, because after that, you don't control anything. How do you personally deal with the lifestyle? You just consider it a privilege and a blessing. For me, it has been, I have understood this was the purpose I was born. I do it better than anybody else. There is another quick personal 1-minute anecdote I'll give you. In between 2001 to 2005, I started developing tremendous anxiety tremor. I could not deal with it. And finally, it was a wonderful friend who was the senior most 747 captain. He helped me understand. He says, look, why are you anxious? There's nobody who does it better than you. So that fact which came to me, now this is, you have to realize that it's impossible on the lifestyle, and particularly for people. I mean, I'm privileged in a way that this is all I do, but just imagine you've got a full office the next day, you've got interventions, you've got a tower to do at 7 in the morning, and now you are struggling with the 2 STEMIs in the night. Can be very, very challenging.
I appreciate it.
Thanks, Jesse. Important question. Andrea.
Hey, Dr. Mehta, thank you for your talk. I wanted to ask you, how often in your practice do you perform TT before the STEMI, and how do you manage those patients with double symptoms onset? So what about LV angiography and risk of thrombus? What do you do in these cases?
I didn't, Andrea, tell me again. I didn't understand.
I think Andrea was asking, the assessment of LV function and mechanical complications, right?
Okay.
In Milano, for example, when I would get called to do a STEMI, by the time I got to the cath lab, the on-call fellow had done a transthoracic echo and told me everything. He could tell me there was a VSD, the LV function, anything. I mean, do you think there's a role for that in STEMI? And
look, if you've got a sophisticated structure that you're able to quickly assess the LV function as the sheets, as the patient is being prepared, fantastic, absolutely. To me, you have to realize, I used to tell people, and there is a purpose I used to tell them, that I always, even with the hand injection before I take the patient off the table, just imagine you've done a STEMI, you've opened the vessel, now there is this, assessment of LV function is the most incredible triage for a patient. You've got a patient, you've done a door to balloon time less than 60 minutes, but the ejection fraction is 30%. It's totally different than a door to balloon time of 60 minutes and a normal ejection fraction. Normal ejection fraction, there are patients whom I don't even send to the intensive care unit. They can go straight and they are going home the next day. Whereas impairment of LV function, even when I'm going and talking to the family, I'm a little cautious in my prediction and all that. So I think if you're able to do it, you have to, people often say, oh, you're doing LV function, you're throwing, come on, you're using 5 or 6 cc's with a hand injected. This thing takes you a minute after the procedure if you've not had a chance to do a non-invasive with an echo. But if you're able to get that information quickly with an echo, fantastic.
Even if symptoms onset is not so clear, so maybe there may be a thrombus or complications. Do you perform LV angiography the same?
Yeah, it happens. This is where Dr. Scotty, I mentioned, the judgment comes in, and I know cases are similar. There is no guideline which tells you about that. You use your own clinical judgment. In the US, the biggest challenge we are having is the false alarm. The false alarm, which is the ACC says should be less than 11%, that is fiction. The truth of the matter is, in the 5 hospitals I've been doing it, the lowest false alarm is 19%, the highest is 65%. I mean, this is the reality. So those are very tricky issues. STEMI will test you not the procedure, but the judgment.
All right. Samir, if you don't mind, we've still got a couple of more questions. The discussion is just amazing. Samina?
Thank you so much for a great talk. I learned a lot. One of my questions is about the role of 2B3A in your practice. How often would you use them and with what kind of scenario?
Fantastic question. You've done everything perfect. You've got a good result, or sometimes maybe it is not a good result actually. And you've tried my tricks of thrombus management, which is as much as it is a thrombectomy device, it is actually using intracoronary vasodilators. And the result is still not good. There is still timigrate flow. The patient is still having lingering chest pain. I would probably use the 2B3A. Now, when I started this journey in 1999 and 2000, the use of 2B3A was 32%. It is less than 1% now. In fact, the drug to use here is Cangrelor, which I think is absolutely the best drug in interventional cardiology for a STEMI. Particularly, just imagine you're taking patients who are the door to balloon times are 40-45 minutes. We are still giving a patient aspirin and prasugrel and ticagrelor in the ER, really? It's silly. If the price of the drug was less, if there were no constraint, the best drug to use is Cangrelor and heparin or bivalirudin. So I have been fortunate, actually, Asim, this is something which people don't know about my career. I have been the world's first person to use both bivalirudin and Cangrelor.
Wow. Okay. I didn't know that.
Candelor, I think for STEMI is a great drug. Use of 2B3A getting lower and lower.
And do you still use bival or you only heparin now?
I unfortunately, because I have become so good at it, and of course the cost has come down, I'm still using bivalirudin. But
Okay.
look, all the data shows heparin works as well.
All right. Okay. Bob?
Yeah, thank you so much for the talk, Dr. Mehta. Your talk personally resonates with me because I'm from Nigeria, sub-Saharan Africa, and I've learned a lot from the challenges of telemedicine, and this has inspired me, how we can help around the world with STEMI care. I have a specific question about post-arrest STEMI. You're a young attending, you're coming in, you want to help the patients, but you also want to be sensible. I just wonder how you walk through these patients with a higher lactate, higher pH, lower pH, question about their mental status. Now, there has been proven ST elevation when after VT or VF, they got the patient back. How do you walk through these STEMIs where the viability of the patient is questionable? Thank you.
Lovely question. Continue to inspire your fellow countrymen in Nigeria. As I mentioned in the slide, without knowing that I'll have a fellow or a physician from Nigeria, all those the lessons which I have mentioned should be resonating more and more. I have always said the relevance of my work, if I was to take a world map, it is in sub-Saharan Africa. Out of hospital cardiac arrest is now reaching the same methodology like how we used to do with STEMI. The protocols are becoming clearer and clearer. The role of cooling is becoming larger. Beyond that, it is absolutely tricky. You have to realize. Now, the good news, I'll tell you, the bad news is their outcomes are still terrible despite our best measures, which is evolving. The good news is that if systems are great, you have to realize that less than 2 or 3% of the patients will belong to the group you're talking about. And if the common good has been created in just taking care of the majority of the STEMI who are fortunate not to be having this the cardiac arrest. So a very tricky, evolving thing. I cannot completely give you a foolproof answer. None of the cooling mechanisms is either completely effective. Again, now you're talking about the campaign to have all sorts of defibrillators everywhere works, but again, the final answer is, of course, educating the bystanders to be trained in CPR. Some very, very tricky issues there.
Thank you.
Great. Thank you. Manaf, did you have any final questions?
Going last, I think I've had all my questions answered, but Dr. Mehta, I just wanted to say thank you for a very inspirational talk, and your experience is very much evident and valued. I think I speak on behalf of all my other co-fellows. We've very much learned a lot, and thank you again.
Manaf, thank you so much for your kind words.
Samir, I think that's the perfect ending to this wonderful session. I'll only echo what everybody said. It's been one of the best talks we've had in our Monty Heart. It's come from a true world life experience and from your heart to ours. So we thank you again. We wish you well, and we look forward to seeing you in person soon.
Absolutely, Asim. Thank you so much, and has been a great joy doing this.